Hello, everyone. Welcome to this CNE session. So today's session is going to be on common electrolyte disturbances, especially focusing on potassium disorders with our guest speaker, Dr. Hasen Arif. But before starting our session, we're going to have some brief introductory slide about Yetenaweg. So Yetenaweg is an organization registered in Pennsylvania, which is a non-profit organization, and it's run entirely by volunteer members. We currently have over 150 active volunteer members across 5 different countries, and we're counting more. Projects is health promotion, especially focusing on discussions and articles about the health of the general public, as well as focusing on health policy and implementations. The other is community engagement. We undergo different blood drives and inclusive as well as equity projects and fundraising campaigns. The other project is mentorship and skill sharing. We provide direct mentorship, soft skill trainings, career and professional development webinars, and many more. And the other project we have is the medical education project, especially the CME as well as the research and quality improvement projects. One of, as I said, Yetenaweg's health promotion project includes podcasts and clubhouse live discussions, as well as health articles, free online webinars, direct social media engagements, and YouTube videos. These are some of the examples, especially focusing on the health articles. And this is our Yetenaweg podcast. The other is the mentorship. This mentorship project provides soft skill development courses, personal one-to-one mentorship opportunities, as well as international exam preps for USMLE and other exams, and experience sharing live chats with leaders in healthcare. The other is the research project. Yetenaweg together with Roha Research Fellowship, Yetenaweg together with Roha provided a research and quality improvement fellowship program. So these are some of the winners from this project, and this is them taking some of their prizes. And the other is the clubhouse session. And the other project we have is the health advocacy project. Here we work on mental health awareness, disability inclusion in healthcare, as well as cancer care in Ethiopia. And we have many articles written on mental health, as you can see on this slide. And the other is the continuous medical education program, where we provide short webinars on different healthcare topics. The other is donation programs. We donate a lot of books and healthcare. We donate a lot of other things to the needy. We also have health and art exhibition programs. Some of the pictures you can see here. So let's proceed to our session. So before I start, let me introduce our guest speaker for today. So Dr. Hasen is a clinical associate professor in the Division of Nephrology at Thomas Jefferson University Hospital. He completed his medical education from Dow Medical College in Karachi, Pakistan. He completed his residency and fellowship from Drexel University and Hanman University Hospital. He has been in academia for the past 10 years. And today he'll be discussing potassium disorders with us. So Dr. Hasen, you have the floor.
Thank you, everyone. Thank you for having me today. A big thanks to Yetenaweg Health Data and Information. Thank you, Dr. Mulugeta, Dr. Halamariam, and Dr. Tilahoon for having me for this particular lecture. I will be sharing my screen now. Okay, so with this, we're going to get started. So We're gonna run through a few things pertaining to potassium. I'm sure you guys have seen potassium issues in the hospital, and each issue kind of requires a different approach. Uh, First and foremost, I have no disclosure since we will be going through some pharmacology, which is required and used for the management of hyperkalemia and hypokalemia in itself. So the agenda today is potassium distribution, potassium measurement, how the body handles potassium, and then again, the two disorders that we will be dealing with from a potassium standpoint. So most of the potassium is intracellular. It is maintained in that manner because of this sodium-potassium ATPase pump, and almost all of the potassium's body is intracellular with only about 2%, which is the 3.5 to 5 millimoles or milliequivalents that we see on the outside, with about approximately the total body holding about 4,000 milliequivalents of potassium inside the body in itself. This is a diagram and a schematic. This is the intracellular compartment. And as you can see, it holds about almost 4,000, whereas the extracellular compartment holds about 60 milliequivalents only. Through our diet, we get about 100 milliequivalents, and through our urine and our feces, we get rid of about 100 milliequivalents. So all of this stays in balance, provided there's enough coming in and enough going out. If for whatever reason this barrier is compromised, or the cell or the pump that maintains this equilibrium is damaged or cannot function, the levels change drastically. So for the time being, the electrochemical neutrality of the body, and it's a fancy term, but you have about 140 milliequivalents of sodium, which is positively charged on the outside, and balanced by 140 milliequivalents of potassium on the inside. And this sodium-potassium ATPase pump is what is responsible for all this management. Another fancier way of looking at it is that this pump right here in the middle is the sodium-potassium ATPase pump, the extracellular space, the intracellular space. Sodium is constantly being pumped out, potassium is constantly being pumped in. This is against a chemical gradient, hence an ATP is utilized every time this motion is completed. However, there are channels that are leaky towards potassium as well as sodium that allow sodium to come back into the cell, higher potential or concentration of sodium outside the cell, lower concentration of sodium inside, the sodium moves in, and consequently potassium higher inside, lower outside, so potassium moves out. These channels are important, specifically in the cardiac cell, where the sinus node is the first one to have more leaky sodium channels, hence it undergoes depolarization quickly, or quicker than rest of the myocardial structure in itself, hence initiating the action potential that we all see in the heart in itself. Again, any problems in these channels or this pump automatically causes problems with maintaining a sodium concentration of 140 milliequivalents over here and a potassium concentration of 140 milliequivalents over here. And that throws off the action potential and the electrochemical gradient that is generated because of this. These dumbbells that you see are the phospholipid bilayer. So again, most of the potassium that we introduce into the body, again, and I will get to the handling of potassium as well, but it is absorbed. Again, nutritionally, what is required is absorbed by the gut. Electrolytes are a little different. Whatever electrolyte is consumed is absorbed and then handled by the body differently. Most of the potassium that is absorbed in the large colon. Hence, if you think back at what medications we normally use to get rid of potassium from the body, you have all these potassium binding resins that partially and practically act in the colon in itself. All of it gets absorbed into the blood. It is then redistributed. Whatever is excess is then handled by the kidney. And as you can see, about 90% of the potassium that is above the requirement is removed by the kidney, whereas a small fraction is removed by the fecal-oral route. So because potassium is intracellular, what we can tell and we can say by fact and by clinical experience is that whichever organs are largest by mass will have a lot of potassium provided their cell membrane breaks. So in patients who have rhabdomyolysis, i.e. muscle breakdown, your potassium or your patient's potassium will go up. For those undergoing liver necrosis, liver damage, liver breakdown, you will have hyperkalemia as a result of the intracellular compartment coming out. For those patients undergoing hemolysis, you will have hyperkalemia as a result of potassium coming out. Skin is one of the largest tissues. It covers the entire body. So patients unfortunately suffering from third degree or severe burns may develop hyperkalemia as well. And then again, we've all seen these scenarios, unfortunately, where due to certain situations, patient may have a necrotic small bowel or a large bowel, and hence, lo and behold, not only lactic acidosis, but refractory severe hyperkalemia. Now, the problem with all of this is the measurement of potassium that occurs in the blood vessel, and as you can see, somebody's being phlebotomized over here, is that this is the compartment that is being measured, whereas this compartment requires a clinical interpretation. And we'll get to certain questions that we'll do in trying to figure out what is happening in the body. So when managing potassium or trying to figure out potassium, it's not just, hey, we have a value over here. We kind of have to figure out what's going on in this compartment as well. That will help us ascertain whether there is a movement of potassium from this compartment to this compartment, or did the entire potassium value in this compartment go up as a result of either too much potassium coming in or not enough potassium leaving the body. So 90% of the potassium is removed by the kidney, with 10% being removed by the gut. We also sweat potassium out, and our stomach secretions obviously are high in potassium as well. So as the renal function declines, the body kind of has to adjust to this handling of potassium, since the kidneys are not able to do as well a job as they were when they were doing well. So studies have shown that in dialysis patients, the colon, which is the large intestine, can upregulate to about 40% of the function. Hence, in dialysis patients, medications such as Kxalate, Pitiramar, Veltassa, all these medications that we're going to get to in a little while, they actually help maintain and manage patients' potassiums much more clearly and much more efficaciously. So what is required by the kidney to handle potassium? Of all these stuff that you're seeing over here, aldosterone, as well as adequate sodium delivery, which can only occur where there is enough urine flow. These three are absolutely required so that the kidney can do its job. Absence of either one of these three, and the kidney loses its ability to handle potassium. For example, patient is having severe diarrhea. Patient's blood pressures are low. Because of that, the patient will release or activates their renin, angiotensin, aldosterone system. So the patient will have adequate amounts of aldosterone in their circulation. However, because of the fact that most of the sodium is being reabsorbed in the proximal and the thick ascending limb, and not enough sodium is getting to the collecting duct, there won't be any exchange of sodium for potassium. Hence, potassium will stay high until the patient is hydrated appropriately. And then you will see that the patient's potassium starts going down. So just having one does not mean that the body will be able to help itself. Consequently, adequate amount of sodium be delivered to that particular location and no or lack of aldosterone, the entire circuit doesn't work. Now, externally, obviously, potassium keeps on coming in. And these are some of the foods that are high in potassium. All of these foods are more or less considered to be healthy in appropriate amounts. In certain scenarios, obviously excess or under certain situations, healthy foods can be unhealthy as well. For example, patient with renal failure or chronic kidney disease, or patient is on angiotensin converting enzyme inhibitors, angiotensin receptor blockers, or aldosterone blockers, and lo and behold, all this healthy food unfortunately turns into unhealthy because of the fact that potassium then starts holding into the body in itself. Dry fruits are higher in potassium as opposed to the same fruit in a non-dried form. So for example, fresh figs are going to be lower in potassium as opposed to dry figs. Raisins are going to be higher in potassium as opposed to grapes. And the reason being, at any given time, because of the volume, when it comes to eating grapes, you might be able to eat 10, 11, 15. When it comes to eating raisins, you might be able to get away with more. And hence, the same stuff is concentrated, and that's what creates the issue in itself. Salt substitutes, such as Morton's, obviously, you're trying to get away from adding sodium to the equation. And hence, the only way to provide another form of chloride would be potassium chloride, because it's soluble just like sodium. And hence patients who are hypertensive with chronic kidney disease may come to your clinic where you check their blood work and you will tell them, hey, your potassium's running high. And you run through this entire laundry list and they're like, we're not having any of this. And lo and behold, they're basically using a salt substitute to season their food. This others column is more notorious than the fruits and the vegetables. Yogurt, ice cream, peanut butter are very high in potassium by weight in itself. So again, they are mostly processed, especially in the US. And in order to preserve the food that is being produced, they usually use a potassium-based salt. Hence, any patient who's consuming any of these products ends up being hyperkalemic if it is done on a repeated basis. This is not a one-time deal that you had 1 cup of yogurt and you're going to be hyperkalemic for the next week. You need to repeat and kind of compound the amount of potassium going into the body that results in hyperkalemia. So, as I had already stated, aldosterone and distal sodium delivery is required for the potassium balance. Aldosterone is a mineralocorticoid hormone. It is triggered by both hypovolemia and hyperkalemia. And so the two triggers are independent of each other. So you can have a normal blood pressure and still have aldosterone in the circulation if you are hyperkalemic. For example, you're doing well, you're hydrated well, you ate a bowl of yogurt and then you had some ice cream afterwards. Your potassium in the blood will go up. You do not need blood pressure at this time. However, the potassium concentration in your blood has gone up, and that will trigger the release of aldosterone to get rid of the potassium in your circulation. So without aldosterone, the kidneys cannot excrete potassium. And again, without distal sodium delivery, this swap for sodium with potassium cannot occur either. So all the way in the corner over here is where these cells exist. This is the glom. This is the proximal, the descending, the thick ascending. This is the distal convoluted. And then you have the collecting duct where the initial portion of all of this has these principal cells. It's a complicated schema. I'll simplify it. This is the blood side. This is the urinary side. This is the cell in itself. Aldosterone is a cholesterol molecule, so it does not have any receptors on the surface itself. It has its mineralocorticoid receptors, which help transcribe messenger RNA, which then helps with these sodium and potassium channels to be placed over here. Even if aldosterone is there, you put these channels on here. If there's no sodium coming all the way out here, this exchange between sodium and potassium does not occur, and your potassium values in the blood continue to stay high. So with that, we will start with hypokalemia first. It is what is defined as less than 3.5 milliequivalents or millimoles as far as the extracellular compartment is concerned. Not intracellular, extracellular. This is an extracellular measurement. So hypokalemia can occur as a result of transcellular shift, and there's a bunch of drugs and situations that can cause this. We've all seen this in the setting of inhalers that are being used. So if there's an asthmatic that is having an asthmatic attack and they keep on using their albuterol inhaler, that can cause a sudden transcellular shift at the time of the measurement of the blood. Renal potassium losses, i.e. in the setting of a few genetic issues, along with severe hypomagnesemia, diuretic use, all of which can cause potassium loss. Extra renal losses can occur either from above or below, meaning to say if somebody is vomiting precipitously or they are having diarrhea or using laxatives, that can lead to extra renal losses as well. Patients who have undergone surgery with an NG tube can have severe potassium losses as well. And now again, with this portion being, if somebody is on a really low potassium diet, remember in the first few slides I showed that there's a certain amount of potassium coming in and a certain amount of potassium being excreted. If there isn't enough potassium coming in, that amount of potassium being excreted is going to maintain itself. So you're going to continue to deplete your potassium stores over a period of time. The reason why we lose potassium, even though the body should be smart enough to hold on to it, is because potassium is utilized as a positive ion to hold on to negative ions so that you can get rid of them. These could be in the form of antibiotics, these could be in the form of bicarb and other stuff that is there that the kidney needs, because the kidney again needs to produce something that is neutral. So in order to do that, the only two electrolytes it has is sodium and potassium. So there will be a constant loss of potassium if it is not repleted. All these factors in different mechanisms lead to hypokalemia. The one that I would really like to emphasize on is magnesium. One cannot correct potassium losses if the magnesium levels are not appropriate. Our cardiology colleagues, including our nephrology colleagues, will always make sure and harp on all of us to make sure that the magnesium levels are high. I will get to the mechanism of how and why that occurs. Needless to say, just think of it as magnesium is the bigger brother of potassium, and it is the more wiser and the more responsible of the two. So when the parents are away, magnesium is the one telling potassium, hey, no, this is not the right time to go out. It's too late. So when magnesium is in there, potassium is basically out partying, i.e. it's lost or left the body completely. So when magnesium is in its better or higher concentrations, it prevents potassium losses. So whenever you're running into a patient where you're having difficulty repleting potassium, check the magnesium levels. If the magnesium levels are low, focus on repleting magnesium alongside repleting the potassium levels as well. These genetic abnormalities would be rarities in themselves, even though they are very fun to learn. But for the most part, you'll be dealing with diuretics, you'll be dealing with alkalosis, beta blockers, insulin, all these things that are going to be bread and butter for all of us for the most part as we are managing these patients. Now, how to evaluate a patient with hypokalemia? Obviously, the first thing that we do is we get this value, which is usually a lab alert. Check the magnesium and replace if low. If there are warning signs present, we start urgent therapy, and I'll show you what that urgent therapy looks like. If no, consider pseudo-hypokalemia, i.e. has the sample been sitting out too long? Is there anything that might be hampering the measurement of potassium in itself? If yes, no further action is required, because what we'll do is if we start treating a number and this is a false value, we can create actual hypokalemia in the patient because all the medications we use, or we can cause, hyperkalemia, because we'll be trying to treat low potassium with potassium supplementation. Then you look at if there's any evidence of decreased intake or transcellular shift. If yes, treat according to the etiology of transcellular shift. If no, meaning to say there is actual reduction in the total amount of potassium in the body. Since we've already said that 90% of the potassium is handled by the kidney, the culprit or the first organ that we look at is, hey, is something going on in the kidney? So if the kidney is not getting rid of a lot of potassium, i.e. your potassium is low in the blood, and the kidney is holding on to potassium, i.e. it's reabsorbing as much as it can, you're looking for extra renal losses. Plus, to tell you the truth, this will be evident from the patient history as well. So a gastrointestinal loss, meaning to say patient coming in with vomiting, it's not going to be hidden. They're going to be throwing up. If patient's coming in with diarrhea, their primary complaint will be, doc, I'm having diarrhea. If they're on a diuretic, it will be glaring and facing you in the face right there and then. So these things are very easy to pick up from the history in itself, and it just solidifies what you've been looking at in itself. If the amount of potassium coming out in the kidney is really, really high, then you're looking at renal losses. When looking at renal losses, always look at whether the patient has high blood pressure and hypervolemia or not. If yes, then you're looking at mineralocorticoid activity, heart failure, all that other stuff. If no, then you're looking at acid-base disturbances. And again, we'll go through these scenarios to kind of see how this is applicable. Again, this is not an end-all and be-all. So it's not the absolute. You will find other algorithms, and whatever suits your fancy, as long as you're covering all these bases, is what you should make a habit of looking into and doing in itself. Now, the treatment of hypokalemia, if your patient's potassium levels are less than 3 millimoles, my recommendation would be that this should be IV administration. The IV administration, again, there is a limitation for how much IV administration you can put the patient through. Remember, potassium can cause sudden cardiogenic and cardiorhythmic results. So your pharmacy will tell you that this is the maximum amount of potassium for a maximum amount of rate of administration. Doesn't mean that you can't piggyback one after another into the patient. Repeatedly check their potassium levels, and if they are able to concurrently take oral potassium supplementation, allow them to do oral supplementation as well. Now, if somebody is from 3 to 3.5, oral supplementation should be adequate enough. And again, I cannot emphasize this again and again. Magnesium should be checked for the correction of potassium. Otherwise, you're going to have a patient who's refractory to therapy. So when I was telling you guys that magnesium is required for preventing further losses of potassium, this is the urinary side. This is the intracellular side. Potassium through this particular channel moves out. However, if magnesium is available over here intracellularly, it prevents potassium from leaking out and hence prevents potassium losses. So magnesium repletion and supplementation is absolutely necessary. There is no technical limitation, and you can actually use the same IV supplementation, and you can actually add magnesium to that same supplementation as well, so that you can get 2 for 1 deal. Now, case 1 is a 32-year-old patient, history of hypertension and asthma. The current medications include albuterol, atenolol, hydrochlorothiazide. The patient is admitted to the hospital with diagnosis of exacerbation of asthma secondary to bronchitis. The patient is treated with albuterol treatments every 3 hours. They are started on an antibiotic and a prednisone taper. Patient sees atenolol is stopped due to fear that it may exacerbate the asthma. That is actually appropriate, but not really. Anyway, but it is stopped due to fears. After 24 hours, patient C complains of severe muscle cramps despite the fact that their admission potassium was 3.9, which is within normal limits. A repeat chemistry is done, and it shows a normal renal function and a potassium that has dropped down suddenly to 2.9. Patient C is given 40 milliequivalents of potassium immediately and prescribed 40 milliequivalents twice a day with close monitoring of the level. So what could be the potential causes of patient C's hypokalemia? I will go back to the question, and as you guys read through it, you'll be able to assess a few things that may either cause actual loss of potassium from the body, or you might see that they might cause a transcellular shift from within the body. So I'll give you guys maybe a couple of minutes just to kind of read through this question again. I know it's a little dense, but this is how patients. Okay, good. So I'm getting answers pertaining to albuterol. Excellent. Transcellular shift is high likelihood as well. Um, Again, any medications on that list that might cause actual loss of potassium from the body? Good. So we have albuterol and diuretics. Good. HCTZ, that's the diuretic, that is the patient is in use. And any thought process about the steroids? How would steroids cause, would they cause any loss of potassium? Would they hold on to potassium? Okay, so let's get on to the answers over here. So hydrochlorothiazide, we all understand it could be direct loss. It could be also because of magnesium losses. Great. Albuterol, transcellular shift, we all got this part correct. Perfect, excellent. Prednisone, over a period of time, it will behave like a mineralocorticoid, and just like aldosterone, it can result in renal losses because it will activate the same pathways and channels that aldosterone activates and will cause potassium losses. And the last but not least, cephalosporins. These are negatively charged antibiotics. And like I discussed earlier with you guys, um, the urine has to be neutral. If you give the patient an antibiotic, it'll either be negatively charged or positively charged. If it's a positively charged antibiotic, it'll flow out into the urine with a negatively charged ion with it, so that it's a neutral compound. Cephalosporins are negatively charged. So in order for them to be excreted by the kidney, they will require something that is positively charged. In the urine, most of the time, sodium and chloride are buddy-buddy, so they kind of travel with each other. So it leaves kind of the only one that is in abundant amount and does not have anybody going out with them is potassium. So the potassium can be dragged in the setting of cephalosporins as well. So these are the few ways one can have hypokalemia in this patient. Again, the last two are a rarity, but you guys got most of the reasons and the rationale correct. So great job. And again, please check magnesium. Obviously, this patient's on hydrochlorothiazide. So magnesium losses, if not repleted, no matter how much potassium we give this patient, this will not correct the renal losses in themselves. Okay. Now, moving gears towards hyperkalemia. Hyperkalemia is defined as any patient with a value, extracellular value of greater than 5 milliequivalents per liter in the blood. Over here, obviously, there is a pseudo hyperkalemia or a false potassium value where either due to an inappropriate blood draw or certain other factors that are there in the blood that can result in the value being higher than normal. For example, somebody did a phlebotomy on a patient. The needle size was very small, and as the blood was being drawn from the patient, obviously that will cause shearing or breaking of the red blood cells. So the sample automatically will have hyperkalemia. Why? Because red blood cells, the walls or the membrane has been broken and all that intracellular potassium has leaked out. The other scenario that I've seen is where blood has been drawn into a syringe and then it has been attempted to be added into the tube. So because it was added into the tube, this is a vacutainer. Because this is a vacutainer, it will pull blood through the syringe in itself. And at the pressure it pulls, it causes shearing as it's coming out. So that can cause an abnormally false value of hyperkalemia when the patient never had it. Potassium retention due to excessive intake or endogenous potassium load. We've already gone through some of this. Plasma aldosterone, cortisol, or renin activity, meaning to say that what was required by the kidney to manage potassium is not there anymore, unfortunately. And hence, due to a lack of aldosterone, due to a lack of trigger for aldosterone, due to drugs that inhibit the renin-angiotensin aldosterone system, or due to a lack of enough sodium delivery distally, we are unable to manage, or the body is unable to manage or handle the potassium in itself. Okay, these are all the causes, again, that can lead to hyperkalemia, and these are the mechanisms. Some of these are cellular shifts, others are related to impairment in either the kidney function or certain medications that may depolarize the cell membrane. So, for example, certain patients, especially anesthesia, calls us for um, consults on dialysis patients that are undergoing um, intubation, or they need general anesthesia, for which, succinylcholine might be a factor in itself. It's a short-lived factor, but in that short time, it might lead to a cardiac event. So we try to avoid or tell our colleagues not to use succinylcholine in that situation. Um, Transfusions can lead to hyperkalemia as well. Remember, transfusions, the blood that is in the packed red blood cell has been sitting there for a while. So some of the older cells may break down, and hence can lead to hyperkalemia in itself. Some of the genetic situations are a rarity in themselves. So most of the time, you'll be dealing with this stuff. You'll be either dealing with a patient who's suffering from severe acidosis and impaired kidney potassium excretion because of all these medications, a sudden shift from intracellular release secondary to either cell or muscle damage, or certain drugs that are used in the management of these patients. So, when it comes to managing these patients, obviously, if the potassium value is greater than fine, the first thing the lab, when they call you and tell you that the potassium is higher, just ask them, and do it politely, was the sample hemolyzed? And lo and behold, that's where your answer will be. Because if the sample was hemolyzed, okay, fine. We'll send another secondary sample for you guys right there, right now. If there are warning signs present, I will show you what that urgent therapy looks like. If no urgent signs are present, work up the patient for pseudohyperkalemia. If that answer is yes, i.e., there was something that was hampering the measurement of potassium, or the sample was sitting out for too long, or the phlebotomy was done inappropriately, all of that can lead to hyperkalemia, and no further action is required other than repeating the sample itself, just to put your mind at ease and the patient's mind at ease that there's nothing wrong with them. If there is no pseudohyperkalemia, then look for either an increased intake or transcellular shifts. Dr. Halamariam, who's my colleague, will attest and tell you guys how many times we walked into a patient's room and found potato chips, Doritos, all kinds of goodies. But unfortunately, all of these are flavored and high in potassium. We've had dialysis patients who were given orange juice, and multiple packets and multiple bottles of orange juice, just because the patient was worried that their sugars might drop. So look for intake, and then look for transcellular shift. If there is increased intake, temporize, work up the patient while the body tries to get rid of all the potassium from the body, and you can utilize whatever you have at your disposal to do that. Um, if there is a transcellular shift, why did it occur? Was there a medication? Can we get rid of it? If no, again, the question becomes is, again, your potassium levels are high. Ideally speaking, your kidney should be getting rid of as much potassium from the body as possible. So in that situation, is the kidney doing what it's supposed to do? And this is where one of the questions is answered. If it is, or is it not? If it's not, why? Is there kidney injury? Is there a medication that is preventing the kidney from doing its job? Remember the two things that we spoke about when it comes to the kidney handling potassium is enough sodium being delivered. So this is the urine sodium that you're measuring in the bladder, which means enough sodium got out through the kidney, which means there's enough being delivered in the distal tubule as well as the collecting duct. So there's enough distal sodium delivery. Now, the next question should be, is there enough aldosterone in the circulation? Is the patient on any medications that might be causing the aldosterone to shut down? So medications that cause aldosterone to shut down are, and let's look at the answers. This is not even in the question section. So what do you guys think? What medication can cause aldosterone, even though it is there, not to function? It's a common blood pressure medication that we use. Exactly, spironolactone. So patients with spironolactone on board automatically can have issues with management of their potassium, even though it's not an avid strong medication, but you've basically kicked one of the mechanisms that the kidney uses to manage its hyperkalemia management, and hence a small dose of aldosterone can go a long way in these patients. Now, if aldosterone is there, why is the patient not responding appropriately? And hence we start looking for other reasons for whether there's adrenal insufficiency, are there any other medications such as angiotensin converting enzyme inhibitors, angiotensin receptor blockers. All this stuff can cause problems with the patient. If the renin levels are high, are there any primary tubular defects that are leading? And as much as we would like to focus on these, they are rare, but they are still there. Now, non-steroidal anti-inflammatory drugs are notorious in themselves that they can cause hyperkalemia, because even though all the mechanism is there, they impair the tubule from being able to excrete or secrete potassium. So ibuprofen, naproxen, ketorolac, diclofenac. Again, these has to be taken in high doses, and they have to be taken in repeated doses for them to cause the problems. It's not like one dose and something's going to go bad. Okay. So kind of have to put things into perspective. Now, this is the management of the emergency part that we were talking about, the urgent therapy part. So here's figure 3. Here's your potassium value of greater than 5. If the potassium value is 5 to 5.9, and there are risk factors, you have to evaluate the patient for cause, dietary considerations, medication adjustment, and not just Kxalate. This asterisk also means that you have other medications that are available. These need to be administered. The problem is they take about 6 to 8 hours before they kick in. So just because the patient got this administered doesn't mean that you've done or the patient's potassium is going to come down. The patient's potassium will not come down until they've had a bowel movement. If the potassium is greater than 6 and there are EKG changes present, you have to start with calcium administration. This has to be done IV. This has to be done through preferably a central line. I know there are certain calcium preparations that can be run peripherally. Please make sure that the IV line is stable and that there is no signs or chances of an infiltration. The reason being, if calcium infiltrates into the surrounding tissue, it will cause necrosis, and that necrosis is reversible. So your patient will be sitting on 2 problems instead of 1. Along with that, since the EKG changes are present, you're going to start with your insulin administration. You're going to try the nebulizers. If things are not looking good, even dialysis would be on the table in itself. You will continue the EKG monitoring. Why? Because any administration of these drugs will cause a transcellular shift. Potassium gets better. The EKG changes, which are peak T waves and all the other stuff that we hear about, goes away. But that doesn't mean that it's going to stay away. In about 10, 15, 20 minutes, all this medication is utilized by the body and gotten rid of. And so what will happen is the potassium will start getting back up again, and you will start seeing these changes again. And that is when you hit the patient with this stuff again. Patient will require serial monitoring, and if the potassium comes below 6, you can continue this route and not have to if it doesn't go below 6, then you return to A. If it does go, then you continue to monitor and continue to figure out why they got into this situation. Here's another algorithm, almost the same thing, but with certain doses as well. Now, remember, there's one thing that we have to kind of talk about, and that is the acuity of how quickly the numbers went up. I'm sure you guys have taken care of dialysis patients. I've taken care of dialysis patients as well. Some dialysis patients live at 5, 5.5. If they go up to 6, you will not see any changes in their EKG. In fact, they kind of live around there. So there's no emergency to try to start treating them. However, if a non-dialysis patient, like, okay, for example, I ended up in the hospital, I saw some video or vlogs that were telling me that kale smoothies are great for you, and I've started drinking 3-4 kale smoothies a day. I come into the hospital with severe muscular weakness and cramping. You check my blood levels and my potassium sitting at 7. Practically speaking, I have normal kidney function as much as I know. So if I went from 3 to 7, that's going to be a problem. So the change is what is more important than just the final value as well. So you will have patients where their values will be high and you'll be like, hey, why is there no EKG changes? Why is the EKG still looking normal? And those would be patients who are more or less chronically hyperkalemic, like our dialysis patients. Not to say they don't need to be treated, they need to be given a good talking to. You need to still figure out what else is happening in their life. Are they on certain medications? Are they eating the wrong stuff? Are they not getting adequately dialyzed? That might be leading to this particular scenario, and so on and so forth. However, if there is an acute rise, that's when you start seeing the EKG changes and the weakness and the other symptoms, and hence this particular entire algorithm comes into play. Now, if they have good kidney function, you can utilize diuretics and sodium bicarbonate both to actually use as potassium binders. Remember when I said that negative ions need somebody to go out with in the kidney? And we had this given this example of cephalosporins causing hypokalemia. You can actually use that to your advantage. If you give the patient enough IV sodium bicarbonate, the sodium sticks around. The bicarbonate that the kidney needs to get rid of needs a negative ion with itself, or sorry, a positive ion to go out with. And hence, you can actually create what is called a bicarbonate drag. The potassium has to link to bicarbonate so that the urine is neutral. And you can actually reduce the potassium content of the blood. Also, it creates alkalosis. And as we saw in hypokalemia, alkalosis can lead to hypokalemia. So in the case of hyperkalemia, we can use it to our advantage and bring high potassium levels to normal potassium levels by the use of sodium bicarbonate. Again, use it cautiously. Use it when you are sure that your patient has a renal function. Because if you start giving them sodium bicarbonate and they don't have working kidneys, you might cause volume overload. Similarly, over here, diuretics can be utilized as well. Diuretics work really, really well. Again, you need a patient who is volume replete. So this particular combination might be a good idea in patients who have renal function. So do not do this in a dialysis patient. This will not work. In a dialysis patient, just jump to dialysis. Period. What's the point? Right? You already know they don't have any of this working. So just jump onto this. Now, consider potassium binders. There are 3 potassium binders that are available on the market. Okay. One of them is the oldest one that we know of, and that is called sodium polystyrene, also called Kxalate. It is a sorbitol preparation that basically causes diarrhea. And because it causes diarrhea, you basically, or your patient basically has a bowel movement and they are able to get rid of the potassium from their body. The second kind, or the 2 other kinds, are pteromer as well as sodium zirconium salicylate, both of which do not cause diarrhea and help the patient remove potassium from their body through the bowels. Apologies. For all the 3 to work, the patient needs to meet certain criteria. Number 1, they need to have a working colon. Meaning to say, if they do not have a working colon, i.e., their colon was either removed during a particular surgery, or they are obstructed, or they have an ileostomy where there is no connection to the colon, you can give these medications as much as you want, they will not work. So the medication never got to where it needs to get to, and so the effect of the medication is not available to you at all. So make sure if you give these medications in a patient who's constipated, they will have a bowel perforation because these are promotility agents. So all it will cause is a fixed object. Here's the medication trying to move, and then lo and behold, you have a bowel that bursts. So be wary, be careful, evaluate your patient appropriately before giving these medications. Now, for management-wise, temporization, albuterol and insulin with dextrose. Remember, dextrose is absolutely important, regardless of your patient being hyperglycemic or not. High blood sugars kill a patient maybe 20, 30 years down the line. Low blood sugars kill patients in about 30 seconds. So when in doubt, if you don't have a sugar on a patient, hit them with the sugar, then give them the insulin. There have been instances, at least in my career, where the nurse was a little inexperienced and they gave the insulin first. And unfortunately, because the patient moved, they lost the IV line. And now you're stuck with a patient who's received insulin, IV, and cannot get the sugar supplementation because they don't have an IV line. So when talking to your colleagues, when talking to your nursing staff, when talking to your residents, your fellows, whoever are helping you out, make sure that you drill it into their brain. Give the sugar first, then give the insulin. Okay? Hardly any contraindications when it comes to giving insulin. Half the dose of the insulin should be given to dialysis patients. Do not give full doses. Okay, usually the algorithm says 10 units of insulin or 10 units of regular insulin. In dialysis patients, give half because they can drop very, very quickly. Sugar-wise, not potassium-wise, but sugar-wise, definitely. Now, albuterol inhalation, excellent. However, albuterol is a beta agonist, right? Beta agonists have an effect on the cardiac rhythm as well. So if you have a patient who has known cardiac arrhythmias in the form of atrial fibrillation, in the form of atrial flutter, in the form of sinus atrial tachycardias, the last thing you want to do is trigger one while you're managing somebody's potassium. So in that population, the albuterol inhalation might not be a good idea. So again, choose your weapons wisely. Again, removal depends on what organ is working. So if the kidneys aren't working, diuretics are not useful. You need volume to be able to help the patient. And the patient has to be volume loaded for diuretics to work. So if a patient is coming in dehydrated, do not give them diuretics. Flood them with fluids. And as soon as the kidney sees enough fluids along with salt, they will start dumping out the potassium. Potassium resins, we already discussed these three. Remember, not to be given in a patient with constipation, not to be given in a patient who does not have a colon, not to be given in the patient who has an ileostomy and no connection to the colon. And then obviously, the last but not least, the absolute way of getting rid of potassium from the body would be renal replacement therapy, reserved for both chronic and acute patients. We have done it. We need to do it. It's a life-saving therapy. It's a life-saving requirement. It gets the job done. So, patient 56-year-old, diabetic, hypertensive, currently being treated with metformin twice a day, lisinopril 40, amlodipine 10. Blood pressure is 146/83. Beautiful. Lab work reveals the following abnormalities. BUN is up to 83, serum creatinine 4.1, potassium 7.3. R is rushed urgently via medical emergency services to the local hospital where an ECG is obtained. Blood gases are sent out to rule out lactic acidosis, obviously diabetic, renal failure, and on metformin. EKG shows widened QRS waves. Patient R is showing signs of muscle weakness. Patient R is treated emergently with calcium gluconate. And again, as we saw in the algorithm, there is EKG changes. So you're not going to wait and you're going to administer the calcium gluconate. An infusion of 10% dextrose and insulin is started. The potassium levels are sent stat. What could be the potential causes of patient R's hyperkalemia? And again, I'm going to do this. I'm going to go back. I'm going to show you these options again. Good. Lisinopril, CKD, excellent. To tell you the truth, I think these are the only two that I can figure out for now myself as well. Renal failure, excellent. So this could be chronic kidney disease. This could also be acute on chronic. or this could be all acute. Good, perfect, perfect, excellent. So let's look at the options. Renal failure, great. Metabolic acidosis is a possibility, okay? And obviously lisinopril, perfect, excellent. Case continued. Patient R has no urine output for the past 4 hours. Bladder scan negative for urinary retention. Volume status is overloaded and not responding to diuretics. EKG still showing T waves. What's the next best step? Good, dialysis. Good, good, good. So renal replacement therapy would be the ideal way to get around this problem, okay? Now, there are scenarios where patients may be making urine as well, okay? And in that scenario, remember, you need a lot of urine to be able to handle all this problem that the patient is going through. So just because the patient made 500 cc's of urine, you cannot rely on that amount of urine for the clearance in itself. So in that situation, even though the patient is making urine, you would have to have that difficult conversation with the patient stating, hey, you might need to have dialysis and it is in your best interest that you do have dialysis. So with this, we're going to start with some questions. If the panel is okay with it, or should we hold for questions pertaining to the literature that I've just presented, and then we can move on to the questions afterwards. Dr. Mulugera, how would you like to proceed?
We can start from the question.
Okay, perfect.
We have collected some questions and they're still ongoing. Should we start with that?
Yes, we'll start with those. Okay, perfect. So this is one of those questions. This is like slide number 2, slide number 3. Remember, I had shown you a diagram of what potassium might be on the inside and what potassium might be on the outside. Okay. And I have created 4 scenarios and 4 clinical scenarios, and we just kind of have to match which scenario goes with which. So scenario 1 is a high potassium on the inside of the cell and high potassium on the outside of the cell. Scenario 2 is low potassium on the inside, high potassium on the outside. Scenario 3 is low potassium on the inside, low potassium on the outside. And scenario 4 is high potassium on the inside and low potassium on the outside. Okay, these are not repeated. So once it's used, don't worry about it. If you've gotten the answer that you assess, this will not be repeated. So A will not be this, and this. Okay, so once one option is used, it is used. So what could be one of the causes of high potassium? High potassium. And I will go back. Scenario 1, dialysis. Good, good, good. Excellent. Absolutely right. Okay. Scenario 2 is low potassium on the inside, high potassium on the outside. So since A is out of the question, we have DKA, diarrhea, and albuterol administration. Good. Diabetic ketoacidosis. Diabetic ketoacidosis will cause a transient shift of potassium from the intracellular compartment to the extracellular compartment. The thought process is hydrogen, which is the metabolic acidosis part of it, will be moved intracellularly. So you have intracellular positive ion here, and that will cause, or that will be neutralized, but because you've added a positive ion here, you will move a positive ion outside. So DK is absolutely correct. Scenario 3 is low potassium inside, low potassium outside, and that's absolutely correct. Scenario 3 is diarrhea. Perfect. You have a constant loss of potassium. Potassium from the inside will try to keep on refilling this, refilling this, refilling this. And since the patient is continuing to have diarrhea, your potassium content will continue to go down, go down, go down. And eventually you will be left with low potassium inside, low potassium outside. And now the fourth is obviously what is left. You have created a scenario where the patient has gotten albuterol. The potassium on the outside is low because the potassium got moved inside the cell because of a transcellular shift. So again, this shows you that you cannot just rely on the external or the extracellular potassium as your end all and be all potassium values. Why? Because this does not tell you what the inside potassium might be. Okay, so always, 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 this is where, so again, we know we're in the age of AI. Okay, everybody feels that they'll take over our jobs. AI cannot take over our jobs. There is something called clinical acumen, clinical aptitude, and this clinical aptitude cannot be replicated by an artificial intelligence. Sorry, we do have artificial intelligence that's recording the session today. So no, my apologies. But still, in this scenario, remember, we as physicians will use our clinical acumen to figure out what's happening inside the cell, not outside. Okay, moving on to another question.
The first question reads, how do diuretics cause hypokalemia through a transcellular shift or a renal loss mechanism?
So diuretics cause hypokalemia through renal loss of potassium in itself.
Okay. Okay. So the second question reads, what are the requirements for using a central line in the management of hypokalemia?
So potassium can be given peripherally as well. A central line can be placed. The amount of potassium going into the patient would practically be the same, because we always are worried about suddenly shifting the amount of potassium in the extracellular compartment. In certain patients, you might need a central line because potassium, even at the rate that it is being provided to the patient peripherally, can cause a lot of burning sensation as it is flowing through the peripheral vein. So it's not an absolute. It is a practice in itself. It is there in the literature, but reserve it for patients who cannot tolerate a peripheral line administration of potassium.
Okay. Thank you, doctor. The third question reads, how safe is it to administer potassium via peripheral IV line at a dose above 40 milliequivalents?
So the rate ideally is, even though it is 40 milliequivalents, it's 10 milliequivalents per hour. So the concentrations or the potassium bags that we have, they're about 250 milliequivalents of sodium chloride and 40 milliequivalents of potassium, and they run over a period of 4 hours. So it's ideally about 10 milliequivalents per hour that we're repleting the patient. I think pharmacy will not allow you to add more than that to a bag. That is the peripheral concentration that most physicians and most pharmacies have seen, that does not or do not cause burning from a peripheral IV standpoint. So I would not recommend any higher than 40 milliequivalents at a time.
Okay, thank you, doctor. The fourth question reads, how can we safely continue or stop IV potassium infusion without frequent measurement of potassium levels?
So, how can we safely continue or stop IV potassium infusion? That is a tricky question, and it's a good question. So, I would say, given the fact that potassium, one, you need to have an idea of what the extracellular potassium is, and two, you need to have an idea of what the intracellular potassium would be. You cannot do that by looking at the patient, unfortunately. So frequent potassium measurements would be required initially while managing the patient. However, once the patient is stabilized, for example, let's look at it this way. I came in with diarrhea. Okay, I've been having severe diarrhea for the past 3 days. My potassium levels are at 2. In order for me to get from 2 to 3.5, you had to give me about 3 potassium riders. And you check my potassium levels, and my potassiums are now around 3.5. Now I'm still having diarrhea, but because of the fact that you guys are able to keep up with my potassium intake, I might require 1 or maybe 2 a day, and you might not need to check frequent potassium levels on me because we figured out how much potassium I need on a daily basis. Right? As my diarrhea gets better, you might have to cut down on the potassium supplementation that you're giving me so that we don't run into any hyperkalemic issues with me. So it's all, again, clinical judgment. There is no algorithm that will tell you that at this point you can stop checking for potassium, especially when you're supplementing it.
Okay, thank you very much. The fifth question reads, what is the efficacy of potassium binders in Crohn's disease IBD or asymptomatic megacolon?
So very poor. Ideally, they should not be used for Crohn's, inflammatory bowel disease, even in the setting of an active episode of diarrhea. Potassium binders should be avoided as they can cause, to a certain extent, damage to the lining of the stomach. Oh, sorry, the lining of the colon in itself.
Okay. Okay. The sixth question reads, how should we approach severe hypokalemia in patients with severe DKA? Can you share your experience, particularly regarding the maximum KCl infusion?
So this is an excellent question. If you look at the literature, if patients have severe hypokalemia, that is a contraindication to giving them insulin. However, in the setting of DKA, the only way to manage DKA is to give insulin. So if the patient can take oral supplementation, they should get oral supplementation. These are patients where you will put them on standing IV riders or potassium supplementation, like a 40 ml equivalent of 250 of potassium chloride with 250 ml of sodium chloride, and you will just continue to run it back to back, because obviously you know that that potassium is going to move into the cell as the glucose moves into the cell as well. What you should try to do first is load the patient up with potassium, just like you're loading the patient up with sodium chloride. So you start with your sodium chloride, you start with your potassium supplementation. Once your patient has enough volume in them, then you give them the insulin, recheck, and start the potassium supplementation again. It does happen. It's a rarity, but it does happen. You're absolutely right. And the maximum, you'll get a lot of pushback from pharmacy. You won't be able to go above 40 ml equivalents at any given time. If the patient can take oral supplementation, you would prefer to give them the IV along with the oral supplementation.
Okay. Thank you, doctor. The seventh question says, which central line is preferred, the femoral or the jugular?
So that depends on the anatomy of your patient. It depends on how long you need the line. Jugulars are much cleaner. They can be maintained for a longer period of time. So if your patient is going to be in an ICU setting, or they're going to need a line for a longer period of time, I would prefer a jugular over a femoral. However, femorals are easier to place because of the anatomy and the location of where they are. So if it's an emergency and the ideal equipment is not available for you to place a jugular, then go for the femoral. You're not worried about, dropping a lung or causing a pneumothorax in the femoral area in itself. And it's a quicker access in itself. So depending on the emergency and the timeline that you're looking at, it would be a clinical call or a judgment call based on your patient's situation of what kind of a line would you prefer.
Okay. The final question we have here reads, if a patient has both hypokalemia and hypomagnesemia, which one is corrected first?
Concomitantly, both. So the same 250 cc normal saline bag, you will put 40 milliequivalents of potassium chloride and 4 grams of magnesium sulfate. And you'll run the patient on that drip both at the same time.
Okay, thank you, doctor. I'm seeing other questions that are being posted on the chat box at the present. So let us go through them one by one. You might not be able to see them, but I'll read them out loud and I'll repeat if it's necessary. So one of the questions reads, what is your recommendation about infusing KCl via multiple peripheral line in case of severe hypokalemia where you can't give it via a central line?
So multiple peripheral, so remember, it's the amount of potassium getting into the body that might be detrimental to the patient's health. We want to replete everything quickly. The problem is, can the body handle it? Okay, this might sound very morbid, in the United States, unfortunately, there are certain states where the death penalty is in place. In those states, potassium is one of the solutions that is utilized for causing the death of those inmates that are on, so if the infusion is done, unfortunately, very, very quickly. So if you have a patient who's getting 2 infusions of potassium, they might experience a cardiac event. Okay, so 1 potassium supplementation intravenously at a time. You are allowed to do oral concomitant supplementation because obviously the oral supplementation will go through your gut or your patient's gut, and it will be a slow absorption. If you do 2 or 3 concomitant IV potassium supplementation, you will need to manage and monitor the patient very closely so that they are not having any cardiac arrhythmias. So my recommendation would be to avoid it and not to go with multiple IV infusions at the same time.
Okay. So the next question is related to the previous question, I think. So it says, can we run both magnesium sulfate and KCl in one bag?
Yes, we can.
Okay. Another question reads, in patients with no urine output, what is the maximum possible dose of insulin and dextrose that can be given?
So dextrose as much as you want. Dextrose depending on the concentration. So dextrose comes in different concentrations. It comes in concentration of D5%, comes in D25%, it comes in D50%. Basically, remember what you're trying to get into the patient is sugar, not water. So the higher the concentration you use, the better bang for your buck you're going to get, especially in patients without renal function. Why flood them with fluid when they don't need it? As far as insulin is concerned, my recommendation would be that usually the algorithms tell you to take or give them 10 units at a time of regular insulin. I would prefer 5 and recheck so that you're not dealing with a patient who is now hypoglycemic.
Okay. The other question reads, by how much does oral potassium or IV potassium supplementation of 40 milliequivalents increase the serum potassium levels?
Okay. So if your patient is in a stable state, and again, is it okay if I share my slides?
Yeah, sure. I can stop sharing.
Oh, perfect. Yeah, it's just easier to kind of visualize. So I'll pull up my slides. So remember, when you're dealing with somebody who has a low potassium, you might be dealing with somebody who's here or somebody who's here. Okay. Now, if somebody is in a stable state, meaning their intracellular potassium values are normal. Sorry, I'm going to quickly go back to my previous initial slides. Here we go. So if this value is normal and this value has dropped, when you give them potassium supplementation, all you need to do is fill this portion up. So every 10 milliequivalents of potassium will raise this bracket by 0.1. So if I'm sitting at 3.1 and you need to get me at 3.5, you have to give me 40 milliequivalents of potassium. Okay? Every 10 milliequivalents will raise me by 0.1, provided this section is full. Does that make sense? So if this individual who is at 4.2, if you give them 10 milliequivalents of potassium, they will go up to 4.3. If you give them 20, they will go up to 4.4. If you give them 60, they will go up to 4.6. Provided there is no deficiency in this compartment. If there is a deficiency in this compartment, what you give them here will raise this value and then automatically will be moved over here. Or at the same time, you kind of have to factor this in as well. Where are they losing the potassium from? Why is there potassium loss? Is it occurring in the urine? Is it occurring in the feces? There's something going on that's causing them to drop. So that's how I kind of think of it. So for the most part, the calculation that you look at is for a patient with the potassium that is on the low end, are they intracellularly depleted or not? If they are intracellularly depleted, the mathematics doesn't work and you need to give them more. If they are intracellularly replete, in that situation, every 10 milliequivalents will rise or raise the potassium by 0.1 milliequivalents. And that's how the answer is.
Okay, thank you very much for that, doctor. Another question reads, common problem we face at our hospital is lack of basic investigations. So wouldn't monitoring the urine output be a good tool to look at when managing patients with hypokalemia?
Oh, urine output is absolutely necessary in any scenario. Hypokalemia, hyperkalemia. Remember, you're using urine as a rudimentary method of figuring out whether the patient is hypokalemic because of the kidney or hyperkalemic because of their kidney. And urine output measurements are invaluable in the setting of a clinical case because it tells you whether the kidney is working or not. And it tells you where the problem is from a standpoint of how we need to manage the patient further. Also, if the patient has urine output, you can actually measure the amount of potassium in the urine and you can figure out if there is or is not any ongoing potassium losses, or is the patient not actually losing enough potassium because they were hyperkalemic. So it tells you whether the body is able to handle the potassium or not.
Okay, thank you very much. Another question reads, how frequently should we follow the serum potassium while managing hypo or hyperkalemia?
Okay, so any patient with a potassium that is less than 3, give them at least 1 to 2 riders before rechecking their potassium. Remember, each potassium supplementation is about 40 milliequivalents, right? So if I'm sitting at 2.1 and you gave me 40, where do you think I'm going to end up? 2.5. So what's the point of checking, right? So give me at least 2 so that I'm close to 3 so that you know what's the next step. So it depends on what your potassium levels are coming back as before you decide, okay, no, we're going to just keep on giving the potassium supplementation. So the lower the supplementation, the more, the lower the potassium, the more the supplementation. And then once you're at a better level, then you can repeat the potassium. Once you're comfortable that the potassium is not dropping and your repletion is adequate, you don't even need to check the potassium then.
Okay. One last question that we're going to go over says, most literatures say that a patient will manifest when potassium levels become less than 3. But my question is, up to what level of hypokalemia a patient may not manifest or they may not be symptomatic?
So for the most part, and this is my clinical experience, there is literature out there as well. Hyperkalemia is notoriously asymptomatic. Hypokalemia is very quickly symptomatic. So the moment somebody drops below 2.5, they will definitely show up to your clinic. I mean, there are rarities, there are always exceptions in the case. But from my standpoint, my understanding, 2.5 and below patients will definitely manifest. And the symptoms are very non-specific. If you read the literature, fatigue, tiredness, muscle weakness. I mean, after a long day's work, I feel fatigued and tired as well. But again, you have to put it into the clinical context as well. Is the patient on a diuretic? Are their potassiums being measured? Did they have a change in their diuretic management? All these things, or did the patient just have a asthma flare and they were using their inhalers frequently? That can cause severe hypokalemia as well. Hyperkalemia, like I said, notoriously goes unnoticed. You usually run into it when you check somebody's blood work and you're like, why is this patient sitting at a potassium of 6 and talking to us, right? So hypokalemia, more symptomatic. Hyperkalemia, notoriously hidden. Just make sure that you're monitoring your patients frequently.
Okay, thank you very much, Doctor. I'm looking at a couple of very important questions, so let's just quickly go through them and then we'll proceed to the quiz. So one says, what is the simple calculation for potassium deficit?
So there are potassium calculators that are available. Remember, the lower the potassium you have. So remember, when I showed you this slide, if your potassium value falls over here and it falls acutely, this value has not had enough time to fill this up. So you can actually replete this quickly. If you've been suffering from hypokalemia for a very long time, this becomes, or this tries to refill this particular compartment in itself so that the patient doesn't end up with a cardiac arrhythmia. So what we've been told is in the case of chronic hypokalemia, like for example, somebody is sitting with a potassium of 2.5. Mathematically speaking, from 2.5 to 3.5, that sounds like how many milliequivalents? 100 milliequivalents, right? 0.1 for every 10, 0.1 for every 10. So from 2.5 to 3.5, that sounds like only 100 milliequivalent loss. But that 100 milliequivalent loss does not factor in this. So if anybody is below 2.5, their potassium deficit is well over 200 milliequivalents. Because they've not only lost potassium over here, they've also lost potassium over here. And hence, you need more aggressive repletion of these patients. So there's no linear curve. There's no straight line that, oh, you're at 2.5, you need 40 milliequivalents and you're going to get to normal. If you're at 3.5, you're going to need 40. Above 3.5, it's a 1:0.1. So that equation is there. But below that, it's a log. It's kind of like a curve because you've lost potassium from this compartment as well and you need to replete this. So anybody below 2.5, their deficit is over 200 milliequivalents, even though the mathematics says it's only 100. Because you're trying to refill this compartment as well. My recommendation would be use the calculators that are at your disposal, use your clinical acumen as well, see what the magnesium looks like, and then start repleting the patient.
Okay, thank you very much for that, Doctor. The final question reads, how should the potassium solution be prepared?
So it's usually a 250 milliequivalent bag of saline with 40 milliequivalents of potassium chloride in it. And it's run over a period of 4 hours at 50 mLs per hour to give the patient 10 milliequivalents at any given time. IV.
Okay. We've gone through a lot of questions. I think it's best to proceed to the quiz. So thank you very much, Dr. Hasan. Please make sure to stick around so that we can go over the quiz, the answers for the quiz together. So the first question on the quiz reads, patient presented to the emergency department with a chief complaint of feeling shortness of breath for the past 2 days. She also states that she is currently on diuretics and has a history of IDDM, hypertension, and stage 3 CKD. According to her caregiver and family, she has had difficulty breathing on minimal exertion and constantly appears winded, even at rest. She reports that she is currently unable to ambulate and has been feeling lethargic for 3 days. According to her family, since her discharge from the hospital 1 month ago, her respiratory status has not returned to normal. She also reports having a history of muscle cramping in her lower leg, but currently there is none present. She has been using 2 liters of oxygen via nasal cannula, and just a few days ago, her Lasix dose was doubled to help her manage her CHF symptoms. She reports her quality of life has significantly declined in the last month, and she now requires 24-hour assistance. Patient appears to be alert and oriented to person, place, and time with no focal neurologic deficit. She appears to be cachectic and in respiratory distress. Patient shows reliance of use with her accessory muscles to assist with breathing and has difficulty completing her sentences. Her vitals exhibit tachycardia, tachypnea, hypotension, hypoxia, audible S1 and S2 sounds, and 3 out of 6 ESM at the right sternal border. Serum potassium is 2.1 milliequivalent per liter and magnesium is 1.1 milliequivalent per liter. Upon palpation, abdomen was soft and non-distended. Pulses in the lower extremity were diminished bilaterally to +1. What might be the cause of the patient's hypokalemia? Diuretic use for CHF without close monitoring and potential supplementation with potassium, continued loss of magnesium, none or all. Dr. Hasan, you have the floor.
So the answer is all. Obviously, as we've discussed, magnesium supplementation is important. So continued loss of magnesium will lead to inappropriate management of potassium in itself. The patient is on diuretics for her CHF, and she had her diuretic doses increased. And there was no follow-up pertaining to how she's doing, whether they checked her chemistries after the dose was increased. Remember, in the boards, obviously, there will be one clear-cut answer. In life, you're dealing with multiple things that are happening all at the same time. And in this patient, as you can see, both the potassium levels are low and the magnesium levels are low. She still needs management from her heart failure standpoint. So the answer for this particular scenario is that she's on diuretics and nobody was supplementing her with the potassiums while she's on the diuretics, and nobody monitored her magnesium either. So both, which means the 70%, which is all, is the correct answer.
Okay, thank you, doctor. The second question is how to treat this patient? Aggressive potassium and magnesium depletion while continuing diuresis, immediate cessation of all diuretics, administration of beta blockers, or fluid resuscitation with normal saline. Continue, doctor.
Good. So let's look at the ones that cannot be the right answer. This patient is already in volume overload, which means fluid resuscitation will make her worse. I'm happy nobody chose beta blockers because, again, this is an acute flare-up of heart failure. So beta blockers are not indicated in the management of acute heart failure. They're recommended for chronic heart failure management. Obviously, this is a real-life situation, and we all will run into this situation where a patient will require or is coming in with heart failure exacerbation and their electrolytes are horrible. And in that scenario, we have to continue the diuresis while we aggressively replete the magnesium and the potassium. Now, remember, this patient has CKD. Obviously, with CKD, probably at some point, it might have been nephrology, it might have been cardiology. They may have told her, hey, you have to watch out for certain food items that can cause you to become hyperkalemic. She probably did too good a job. She is avoiding bananas. And again, without any potassium supplementation while being on diuretics, she's continuing to lose all the potassium that is not coming in to begin with. Now, food items that are rich in magnesium, chocolates, nuts, these are unfortunately not a staple part of any individual's diet. So magnesium depletion occurs very quickly in patients who are on diuretics. So unfortunately, it has to be depleted with supplementation in the form of magnesium pills. So this is how this patient will require continued aggressive diuresis as well as aggressive management and repletion of potassium as well as magnesium.
Okay, thank you very much for that, doctor. The third question reads, a 91-year-old woman presented to the clinic with nighttime delirium and dysuria. The patient's medical history was provided by the patient and her daughter. Her medical history was significant for coronary artery disease, heart failure with preserved ejection fraction, hypertension, hyperlipidemia, obstructive sleep apnea, hypothyroidism, CKD stage 3B, chronic constipation, and depression. Her medications included levothyroxine, paroxetine, melatonin, cyanocobalamin, as needed loratadine, and as needed polyethylene glycol. Her daughter denied that the patient had regular over-the-counter medication use, including NSAIDs. On physical examination, the patient was frail, afebrile, and bradycardic with a heart rate of 58 beats per minute. Her blood pressure was 142 by 58 millimeter mercury, and respiratory rate was 14, with an oxygen saturation of 95% on room air. She was confused, oriented to person only, but not in acute distress. Lower extremity examination revealed 2+ bilateral edema up to the knees, which was around her baseline, with full strength bilaterally. Initial laboratory evaluation showed the following. Reference ranges provided the WBC was 5.9 times 10 raised to 9, hemoglobin was 12, platelets was 174, potassium was 5.9, sodium was 135, chloride was 110, bicarbonate was 17, creatinine was 1.21, and estimated GFR was 39 per body surface area. Blood urea, BUN was 22, calcium was 9.6, anion gap was 8, and urine analysis showed positive nitrites, and microscopy was positive for WBC more than 100 per high power field. She was diagnosed with UTI. In addition to treating her UTI, what is the next appropriate step for managing her hyperkalemia? Repeat potassium levels, start oral sodium zirconium cyclosilate, refer to emergency department and administer IV calcium gluconate, admit to inpatient and initiate hemodialysis, or administer oral furosemide. Doctor, you have.
We have a wide splay of answers. First things first, this is an elderly patient. She is 91. She has a list of problems that she's coming in with. Delirium is very common in the elderly, and it can be triggered with mild infections, which could be respiratory infections, urinary tract infections, and in her case, she has a urinary tract infection. Certain electrolytes can cause delirium in patients as well, and one of the more common ones that can cause it is sodium. Potassium is notoriously not known to cause any mental status changes in patients. This patient does have an elevated potassium, and I'm not arguing whether she does or doesn't. However, at this time, we don't have enough information to justify number one, intravenous calcium administration. Because remember, the initiation or the need for intravenous calcium administration starts with checking an EKG. We do not know what her urine output is like. We do not know whether this is a true value or not. Yes, she does have volume on her, but this is baseline for her. So just because she has swelling in the legs doesn't mean that we start her on diuretics. Definitely no need for dialysis at this time. Again, remember from her past medical history, she does have a history of constipation. So again, remember when we had discussed the 3 different forms of potassium binders, with constipation being a limitation in their use. So at this time, given how she is presenting, without any symptomatology from a weakness standpoint, without checking an EKG, I would be more inclined in repeating a potassium level just for now, just to see where she stands, rather than being aggressive. I mean, she's suffering from a urinary tract infection. These patients are usually running low on their blood pressure. This can turn into sepsis very quickly. So the administration of diuretics would not be my first choice. At this time, obviously, dialysis would not be my first choice. And without an EKG, intravenous calcium gluconate would not be my first choice. And given her history of constipation, sodium zirconium salicylate would not be my first choice either. So I'm left with repeating a potassium level on her just to make sure whether she is high or.
Okay, thank you, doctor. So the last question is, which of the following is the next best step to assess hyperkalemia for this patient? The creatinine kinase, uric acid and phosphorus, haptoglobin and LDH, serum aldosterone, or ECG? Doctor, you have the floor.
We have a great result on this one. I am in complete agreement with the 86% who said electrocardiogram is the first thing that we will do. This patient is not complaining of any muscular issues, which would prompt you to check creatinine phosphokinase. This patient is not suffering from a malignancy. That would prompt you to check a uric acid or what we call a tumor lysis panel, which usually occurs with patients with liquid malignancies that are undergoing chemotherapy and can have spontaneous hemolysis and tumor lysis. This patient is not showing any signs of hypoaldosteronism, which would prompt you to check an aldosterone level. And hence, the first thought that you would have is if the patient is actually having, or we are repeating the potassium on this patient, we should check at least an EKG. And again, in real life, and I know you guys, probably what you all will do is that you will see the potassium in this patient. You will tell your staff, hey, we need an EKG, and please send the sample off immediately for repeat potassium checking. So in real life, what we do versus what the boards and the examination wants us to do are two totally, unfortunately, separate things. But 86% of you got the answer right. We will check an EKG on the patient to see if there's any warranted need from a treatment standpoint for this.
Okay, thank you, doctor. But before we stop, there is a question specific for the first question. So someone said, the patient in question one is hypotensive and she is hypokalemic and she also has hypomagnesemia. And she is peripherally dry with no evidence of congestion on the chest. So why don't we stop the diuretic?
Because she's still tachypnic. So remember, there are a few. When it comes to managing heart failure, the patients can be put into 4 boxes. Patients are either wet and warm. Patients are dry and warm. Patients are cold and warm. Patients are cold and wet. This patient more or less is in the cold and wet zone, meaning to say they're still having tachycardia, they're still tachypnic, they still have, if not fluid in their lungs, but they are examining and behaving like they have fluid in them, which would then still prompt us to diurese them. And there might be an addition plus minus of ionotropes in the management of these patients who have heart failure and are not perfusing well. So hence the diuretic part would still be required, plus minus the initiation of ionotropes.
Okay, thank you very much for that, doctor. We have been receiving a lot of comments specifically on our Telegram group saying it was a very interesting session. So we would like to give our highest regard for you, Dr. Hasan. It has been a very, very interesting and engaging session. So thank you very much for that. Do you have anything you want to say, or should we close the session?
No, it's been a pleasure of mine. I look forward to hopefully seeing you guys in person at some point. And a big thanks to all of you for arranging this. Looking forward to seeing you for the next session as well.
We hope to see you very soon as well, Dr. Hasan. Thank you very much for that. We will be sharing the quiz link as soon as we get it. I mean, the PowerPoint as soon as we get it. And we will be issuing your certificates in about 2 weeks. Thank you very much, everyone.
Thank you. Thank you, everyone. It's been a pleasure. Have a great day. Enjoy.
Have a great day to you too.